Hello and welcome to another PEDro World-Wide Journal Club. Today we will be discussing a non-inferiority randomised control trial comparing telerehabilitation consultations with a physiotherapist for chronic knee pain versus in-person consultations, published by Hinman in the Lancet. Today we have 4 panel members with a mix of experienced researchers and clinicians. So we'll first go around and introduce everyone. My name's Josh. I'm a senior research fellow working at the University of Sydney and have a physio background. I did work in private practice for a few years, but then did a PhD and have more transitioned into the research field. My focus is mainly anything to do with models of care for musculoskeletal conditions.
I'm Rana Hinman. I'm a professor at the University of Melbourne, where I'm Deputy Director of the Centre for Health, Exercise and Sports Medicine. I'm a physiotherapist by background, but I work as an academic where my work is solely research, and my research focus is on chronic joint pain and osteoarthritis, with a particular focus on exercise and non-pharmacological strategies, and also ways of increasing access to care, such as telehealth.
My name's Sandeep Gupta. I'm the head of physiotherapy at Canterbury Hospital in Sydney. I've got a, 20-something year experience with musculoskeletal patients, not specifically knees, but pretty much everywhere in the body. I am also a member of the PEDro Education and Training Committee, along with Josh. And I also sit on the Agency for Clinical Innovations Frailty Expert Advisory Group.
I'm Rhiannon. I'm the coordinator of the osteoarthritis clinic at Canterbury Hospital. So we look after everyone with hip and knee OA, and I'm a physiotherapist by background.
I'm a physio at RPA Hospital based in Sydney. So I've been here for about 7 years now. Predominantly I work in the rheumatology section, so a lot of low back pain and chronic pain management, as well as some inflammatory conditions. And I'm also doing a PhD at the moment with the Institute of Musculoskeletal Health, which I work with Josh.
And so the first question about the PEEK trial will be, what are the implications of the findings? We might go in reverse order and start with Josh.
Yeah, so I guess the implications are there was similar efficacy for both modes of care. And I guess this results in possibly some more options for clinicians and patients, which hopefully equals a better, access to care for clinicians and patients. So yeah, I guess the other implications were there was a suggestion of some routine tele-rehab training for physios. And I think that's a really important consideration because it is a different mode of delivering physiotherapy. And I guess you may not be able to use some of those typical sort of in-house or in-person modalities like, palpation and sort of moving things around with your hands. So you're relying a bit more on your visual and sort of questioning, which is, just something to consider for those who are typically from a musculoskeletal background.
Thanks, Josh. I'll let anyone who wants to jump in as well to add on that.
I'll jump in. I think one of the things, the evidence that this trial provides is there's often been a lot of concern from patients and clinicians, particularly physios, around safety and efficacy and the quality of service that can be delivered via telehealth, and that often concerns around being able to build rapport with the patient. And I think that we've shown in the trial that really those concerns have been refuted. Telehealth was just as safe as in-person care. In fact, therapeutic alliance ratings from the patients were higher with telehealth than in-person care. And as Josh has already talked about, the clinical outcomes were similarly as effective. So I think it's reassuring for patients, and it should be for clinicians, that this is a safe, effective and high quality mode of delivering care, and it should be an option that we offer patients and an option that clinicians should be thinking about and patients and should be offering to their patients.
I would agree with both Josh and Rana. I guess working in, Sydney Local Health District, specifically around Canterbury, and Rhiannon might be able to speak to this a little bit more. We have a large, non-English speaking population. And I guess, Rana, most of from reading the trial, patients spoke English, so they didn't necessarily need interpreters and stuff like that. So would the next step be trying to essentially, I guess, do tele-rehab for, say, ONEs with, say, people from non-English speaking backgrounds to see then what the efficacy might be? Because for us, it can be quite challenging trying to get interpreters, for example, in order to try and communicate better with this clientele, I guess.
Yeah, it's a good point. Our research and was set in private practices, and the reason for that, and I take it that most of the clinicians on the panel here are from public hospital settings, and so the clientele that's often seen in tertiary care can be different to people that are seen in primary care. And in an ideal world, osteoarthritis is managed in the primary care setting, and for better or for worse, in the Australian setting, that basically means that it's visiting physiotherapists in private practice. Now, that's not to say that different minority groups and ethnic groups are out there as well. And you have raised a really important point, which is that to be effective, similar with in-person care, you do need to be able to communicate in the same language. And so it does add another, in some ways it might add another barrier, but in some ways it might also allow, might make, if you could access interpreters, does make it more accessible without them needing to be on site in a clinical rooms, for example, with basically a third person joining in via telehealth. So from that regard, it's not necessarily that there's a greater need for interpreters via telehealth, because the communication is just the same. And I imagine that you'd be encountering the same challenges in booking an interpreter with an in-person visit as you would be via telehealth. But correct me if I'm wrong there. It's been a while since I've worked in the public setting.
No, I completely agree with everyone. I guess the biggest, next step would be that use of the third person. I guess in-person consults, we can usually quite easily tell if it's not quite being interpreted correctly across, whereas I'm not too sure how that would work via telehealth. So I think overall it's great to see that in-person and telehealth are resulting in the same, if not better, outcomes for our patients. And we do offer a lot of our patients telehealth. But it's just, now breaking into that next level, and how would that interpreter situation go? And I think the amount of training too that this article obviously provided physiotherapists seems quite beneficial for it, because we have a lot of just basic technology issues, and just knowing who exactly to call and when we can kind of get in contact with them if we're having any of those issues. So I think that was a really good aspect of the article, that training that was provided to all the physios and clinicians. And I guess then looking at the whole MDT approach of chronic pain joints, and seeing if not just the physio aspect, but some of those other psychological elements could be added into a future study.
Rana, correct me if I'm wrong, during, I guess, the COVID pandemic, I think you guys released the education material for, I guess, training, because I'm pretty sure I ended up doing it. And I know some of the other people in Sydney did as well. And it was actually very useful in regards to that. Is it still there on offer, or is it ceased, just out of curiosity?
Yeah, you're right. We conceived the idea for this trial and kicked off the trial before COVID, and there was no signs of a pandemic on the horizon. And it was always our plan to ultimately release the training that we did for physios after the trial. But then the pandemic came along, and in fact, I think word got out from the physios that we trained for the PEAK trial about how useful the online training was. So we did release it in what I would call a fairly crude form initially, which was basically, because when we developed it for the trial, it was housed on the university learning management system. And if any of you or the listeners are familiar with university LMSs, they're quite good if you're enrolled as a university student in the uni, and that, but they can be quite clunky, and it was really challenging for us to be able to navigate the university processes to get external people to enroll. Nevertheless, we did, and we had something like 7,000 people sign up for that over about 12 months. Since then, we've transitioned and moved. The e-learning course still exists, and it has moved on to a platform hosted by FutureLearn, which is an online training provider, and that's allowed a lot more seamless access by people, and people can still access it for free under a time-limited nature. So I think you get 4 weeks access, which is enough to do each module over 4 weeks. So yes, it's still there and available. And since then, it's also been translated into Spanish. We have a Spanish version, a Portuguese version, and also most recently a simplified Chinese version as well. So that's one of the nice things I think that we've found with working with e-learning approaches to delivering training, is it really does lend itself to translation in other languages. And you know, we're talking here in the context of Australian physios and training, but the thing that was really eye-opening to us during the pandemic was the huge need for training and services in other countries around the world, and the volume of people that reached out to us during the pandemic was really what spurred us into action with, you know, forcing our hand, if you like, to really get that training out there as quickly as possible.
Just curious about the training. Is it very specific to NEOA, or could it be applied broadly to telehealth management of a range of conditions?
In answer to your question, it's both. So the training was obviously designed for the PEEK trial. So the first module is very much about osteoarthritis and evidence-based care, and aspects about that. The second module is very much generic telehealth skills. In the PEEK trial, we used Zoom video conferencing because we wanted to use something that was not specific, expensive medical telehealth software. And again, at the time that we were designing the trial, we wanted something that may have had some familiarity to clinicians or patients, even though the vast majority of people in the trial, including the clinicians, were unfamiliar with telehealth at the time. So the training is set up around using Zoom, but most of the principles and skills in there are applicable no matter what software or platform you use. I mean, many physios, many clinics subscribe to different telehealth platforms, and then the main module is around implementing the intervention for people with NEOA. It applies to in-person care as well as telehealth, but many of the principles and the way that we've structured, it's quite a structured 5 consultation process. Many of the principles and the ways that we've done that and incorporated education would actually apply to other chronic diseases. And so the model of the way that the way the training is set up for the NEOA context, I think there's a lot of learnings that can be applied across other conditions, particularly to other chronic musculoskeletal diseases.
Yeah, I think that's good to know for people who see the training, especially because it's free, that if there's an aspect of it that could be applied, very general telehealth training, because I realise not everyone is given that if they graduated, you know, many years ago. So I think that's a valuable resource. Just to touch on before, we kind of mentioned the non-English speaking population as one that potentially introduced challenges to implementing tele-rehab consultations. Are there any other specific presentations or types of knee osteoarthritis that people would be a bit more wary to implement this intervention?
With respect to NEOA, I can't think of anything specific to the condition of knee osteoarthritis. You know, we know that education and exercise and physical activity are the backbone of care for all patients with OA. So if we take it from that standpoint, there is a place for the types of telehealth consultations that we've done in this trial for every patient. Now, that's not to say that every patient should only have telehealth. And I don't think that should be the message either that's necessarily taken away from the trial, because I think that's often the fear that clinicians and patients have is that it's an all or none thing. You know, where I think we need to be going with future research is starting to look at hybrid models of care. You know, it might be that some people might benefit from an initial in-person visit. And so looping back to the non-English speaking population, that might be where the first visit, it may be in person, potentially with an interpreter or not. But then after that, the follow-up consultations could be via telehealth. In terms of who telehealth wouldn't be appropriate for, it's probably the same types of patients that you wouldn't choose telehealth for any other condition, you know. So people who might have be visually or hearing impaired will find it more challenging. People who are really not confident at all with technology or have lower levels of digital literacy may find it more challenging, and so they may be the types of patients that you would think about. Is this the right format, or do we do this after we've had the first visit or two and we've developed that relationship, and maybe that patient needs a little bit more help and support in setting up the consultations. Having said that, in the trial, we as clinicians, as researchers, didn't help the patients to set themselves up. And it's part of the e-learning training, we gave them a really comprehensive preparing for your consultations booklet that kind of told them and stepped them through how to set up Zoom and set up their account, how they needed to dress, what they needed to have their environment prepared for, so that they were ready to go for that first consultation with the physio. And although some patients did have some challenges, the physios were trained in some troubleshooting to actually help navigate the fairly common types of problems, which we've all probably had. Your audio's not on, or, you know, various difficulties like that. So in answer to your question, no one specific, nothing really specific to osteoarthritis, but more those general considerations with telehealth. And related to that is if you have concern around the diagnosis, or that there might be some concurrent issues compounding the problem. Obviously, our ability to do diagnostic tests is limited over telehealth. So that might be a case again where an in-person visit is needed, followed by telehealth visits.
Yeah, I can go on from Rana there. We try not to offer it to anyone if pure telehealth, if they don't have access to like a regular GP or a primary healthcare practitioner. So if they don't have that aspect, just in case they do need a physical exam. So we do have some people that are added to the patients that we see that are 2 hours away from Canterbury Hospital. And we try to really suss out beforehand if we think that they might need a further physical exam, are they going to have access to someone to be able to do that for them? So that's probably our only presentation type that would be, and it's not so much the presentation type, it's more will they have access to follow up any concerns for it. But yeah, we would offer it to anyone that's willing to do it. The only ones that we wouldn't, as Rana said, if they're quite hesitant to do any form of telehealth or have that low digital health literacy. Besides obviously the poor hearing and vision, I guess it's those that have quite sedentary behaviours already. Sometimes we like to see if we can get them out of their house to add in that social aspect as well, especially if we can get them to any of our group exercise classes, just to try to add that dimension onto it as well. So if they could really benefit from that little bit of social connection, as long as transport to get here is okay, we do try and add that aspect to it, and just to try to not make them focus so much on doing things at home by themselves.
It's interesting. It's an interesting comment about the encouraging the more sedentary people into in-person care. One of the things that we find with our trials, particularly with the telehealth ones, is they often attract the people who are sedentary. Often we find particularly people who with comorbid overweight and obesity. And I think there's something about the telehealth and the comfort of being in their own home, and perhaps part of it with people who might be overweight or have obesity. It might also be to do with the weight stigma. But I think we can't devalue the fact that the telehealth consultation offers that sense of privacy in their own home too, and that might, in some ways, I think, if our trials only offered in person, we wouldn't get those people signing up and volunteering. So it's just something that we've noticed since we've switched to delivering a lot of services via telehealth, is that we do get some really quite immobile, sometimes frail, and as I said, people with quite a number of comorbid conditions who have trouble exercising, who are signing up for telehealth.
Just to touch on what I guess Rana was talking about there in regards to sedentary and I guess fatigue aspects. So working in various hospitals, so COPD patients, so people with COPD, and if they have quite a lot of shortness of breath and quite a lot of fatigue, they actually do prefer telehealth than coming in, because coming in makes them more fatigued. So there's that element as well, where it was actually surprising during the pandemic of who, chose telehealth. And yeah, it was some of these people that were, I guess, very sedentary and very fatigued, because it just meant that they could, I guess, focus on doing exercise programs through rehab without that added burden of travel, in essence.
And one last thing to touch on that, sort of exercising at home, I guess you're going to prescribe exercises within an environment that they're going to be performing the exercises. So that's a barrier, I think, for in-person physios sometimes. You might be sort of coming up with an exercise plan and, using the gym equipment, the bike, these sorts of things. And then it's a matter of what do they actually have access to at home. And so you're finding novel ways to sort of I guess, counteract the barriers that patients sometimes come up with, like, I've got nowhere at home that I can do this. You're doing the telehealth consultation. You can assess the area and say, oh, look, this is quite a free space, and you've got these bits of equipment, or you've got these sort of household items that you could use to do your exercise plan. So that can be a really effective way of kind of showing patients how they can best set up their home environment for exercise and what to use in order to carry out that exercise.
Yeah, it's a really good point, Josh, and some qualitative research that we did a number of years ago before the PEAK trial, with looking at how patients felt about telehealth, and that's exactly what they said. They really valued the experience of being able to exercise in their home, felt it was a really positive aspect, felt it was really personalised, and actually felt like the physio was visiting them in their home, even though they're remote and far away. So it was that was really eye-opening research for us to really hear those comments from the patient. And I think that ability to sort of tailor what you're doing and see the actual environment that someone's working in and exercising in, the patients really value that.
That's great. And I think another part of this trial that it may be overlooked sometimes is that a lot of telehealth trials, you explain that you're going to do telehealth before people enroll. And so you typically get people who are very positive about telehealth, and it's a bit of a bias sample. But for this trial, they didn't describe what the intervention was going to be when they recruited participants. And even looking at one of the tables, it said that less than 50% of people thought telehealth was an effective way to deliver care. So even though they got people who weren't that fond on telehealth or weren't a bias sample that were very into that mode of treatment, it still had the effect that it did. So I think that's, definitely a large strength over existing telehealth trials.
Yeah, that was really important to us in designing the trial, that we didn't get this sort of, selection bias of people opting in who were either just people who were super, I guess we were thinking ahead to when we published the findings, that if it was non-inferior, we didn't want critics saying, oh, that's only because everybody signed up, they were all into telehealth. So we worked hard trying to work out how we could recruit people without actually telling them what the trial was about. So we used limited disclosure and just told them that we were comparing different modes of physio care and threw a whole lot of options at them in the plain language statement and explained the trial. So in person, different settings, home visits, telephone, group, individual, so a whole lot of stuff. And I think you're right when you look at, if you look at table 1 in the paper, you're right that a lot of people didn't think, because we asked them about how effective that they thought various forms of physio would be, and less than half of them thought that telehealth would be effective. And I think it was under a very, very tiny proportion of them had actually ever experienced telehealth. So they were largely what you would call a naive sample, if you like. Interestingly, it's not part of this paper, but we've just published another paper where we asked a subset of the people in the telehealth arm, how did you feel when the trial coordinator told you that you've been randomised to telehealth, so that we could kind of get those gut reactions about what people felt. And there really was these two camps of a bunch of people who felt really positive, a smaller group who actually felt quite negative about it, and then a group who felt neutral. And then we asked the negative people how they felt after they'd had their treatment, and a lot of them had shifted. So it was really just these preconceived ideas that people have, and that giving people a positive experience really does change people's attitudes and beliefs. And we found that with physiotherapists as well, in changing their attitudes once they actually deliver care as part of a trial.
And I think that leads nicely to the next question, because I think attitudes and beliefs might be one of the key barriers to implementing. But for other people, what do people see as the main barriers to implementing telerehabilitation consults more broadly in Australia?
I think it's a combination of both patient and therapist bias, I guess, in the end. So if therapists are unfamiliar and haven't necessarily utilised telehealth previously, then that can be a barrier because they don't feel that it is, as effective. Obviously, this trial says otherwise, but there is that aspect. And what we've seen post-pandemic is within hospital systems is that patients, for whatever reason, even if they've had telerehab previously, actually want to come in face-to-face. It's been a weird kind of thing within the hospital system. So we've actually seen a drop-off of telehealth within hospitals post-pandemic. So I guess that those are the two kind of groups. I think it's sort of the bias that sort of Rana sort of touched on of, patients that don't necessarily think this is the best way to go. And then obviously there's the therapists as well. I think therapists really need to push it sometimes with the patients to say, we can do this. And sometimes for patients that are traveling, so Rhiannon talked about some of the patients that might travel a couple of hours to come to one of the clinics here. So that might be one way of, selling in terms of telehealth, that essentially you don't have to travel, and Rana also mentioned, maybe they come for the first appointment and then you sort of transition them into sort of telerehab.
I guess still coming back just to the interpreter use, for us, a lot of them still in the hospital system just want to do a telephone call. And I think that you really do need that audio-visual kind of aspect, especially in any MSK condition. So I guess that would be one of the barriers that you'd probably find in all areas. And I guess too, at the moment, there's still a bit of hesitancy from the older population. I think in 10 or 15 years, we still will probably be a lot easier to roll out telehealth across all age groups, but we'll still have the odd patient come in here with their old school Nokia phone that they can just play Snake on, that obviously doesn't give us any form of internet access, and they just don't have the computer at home. But I think it's improving a lot, especially since COVID. But still, probably the 75-year-old plus age group don't always have access just to the technology and exactly how to set it up. But I think that will change over the coming years with obviously the introduction of smartphones back then.
Just on that point, I was of the same line of thinking prior to reading this article, actually. But then I'm just looking here at figure 1 and the exclusions of only 14 people in the sort of 3,737 people assessed. There's only 14 that didn't have access to a device with internet, which I found really interesting. And I guess in a public setting, maybe we've got a different cohort as well. That's certainly a consideration, because this was done in sort of private clinics and around private clinics. But then the sort of next table 1, had the sort of source of recruitment, which was quite interesting, that there was a large number of both groups, for in-person and telerehab, coming from both social media or email, as well as the major cities, as opposed to like really sort of regional towns and remote areas where you might think the telerehab would be a strength for those inaccessible areas. A lot of them are coming from the inner city, which is quite interesting that they were still interested in a study like this.
Yeah, I think, like I said, I think a lot of people, even for older people with painful knees, traveling to appointments, you know, can be, but again, they didn't know that they were signing up for telehealth. So, you know, all they knew that was that they were signing up for a trial for physiotherapy care. If I could just loop back to the comment that Josh was making on barriers, I think one of the challenges that the physiotherapy profession has, in particular with telehealth, and I think it's unique. I think it's a bit more unique to physios more than other professions, is the public expectation and the professional identity we have tied with our hands and touching patients and doing physical tests. And I think that increasingly is going to be the biggest barrier to implementing telehealth. Prior to COVID, I would have said it's the lack of funding. That problem has been solved now. You know, with telehealth is largely funded by payers the same way that in-person services are. We're seeing access now to training. Physios are getting experience doing it, but I think I think professional attitudes are really going to be something that we as a profession have to challenge, and also those assumptions that we make about patients, and, you know, about that, oh, they won't be able to cope, they're too old, they can't do this. So I think we've got a role to play as a profession in recognising that our skills are just as valuable over telehealth and when we're not using our hands. And we don't have to always be doing complicated assessments with patients for these chronic health conditions where we already know that lifestyle management is a key component of it. So I really do think we've got to start shifting those barriers within the profession. And part of that is also educating the public around what the role of physios is. It's not just manual therapy and massage, but a really key part of what we do is exercise and education and behaviour change counselling, all of which can be perfectly adequately done via telehealth and doesn't need, and in fact, in many ways, our qualitative research with physios has said that they actually found the patients far more empowered when they work over telehealth because the patient expectations are different. They're not expecting hands-on and a quick fix and a passive treatment. So it really, I think it does change that power dynamic and something we probably need to harness as clinicians.
I also think that within the education packages that you rolled out, there was education about, you know, OA, and so there were pictures and diagrams that you could essentially show to patients. So, and I think that was also quite valuable as a clinician to be able to provide to patients. So that can also be a barrier for other musculoskeletal conditions in regards to sort of setting up, you know, the education side of it and the diagrams to be able to talk to and things like that. Yeah. Whereas, you know, as a result of the PEEK trial, we had something ready-made to go to be able to do that kind of thing. So it's less investment for the clinician, if that makes sense.
Yeah, it's a really good point, because to do telehealth well, you do need some extra tools and resources there. So we created an entire video library so that the physios could screen share the shot of the exercise while talking with the patient, because obviously you can't demonstrate something as well as you can in the rooms. And so that whole video library, access to that is available as part of the PEEK training. We created a very detailed exercise booklet for the patients and an education booklet that both sides of both the patient and the physio had during the consultation. So it's a really good point, because as we try to roll out telehealth for other conditions, we need to develop these tools that help the physio deliver a consultation really well over telehealth.
I guess going on to maybe the final question is about health equity, and I think a few people have touched on it throughout this session, that a lot of people in the trial were educated and from, you know, metropolitan areas, and there weren't many from rural or non-English speaking. So yeah, how does health equity need to be considered when we're rolling out tele-rehab consults for NEOA, and how do we prevent there, I guess, becoming more of a divide between those who have access to telehealth and those who can't access these services that are meant to help them improve access?
We actually had about 40% of our participants who were from inner and outer regional areas. We didn't have anyone from, remote or very remote areas. One of the logistical challenges with the trial was we had to recruit participants in locations around our trial physios. We only had 15 physios. Had we had more, and had we had some physios located in very remote areas, we would have been able to recruit there. So really the reason we couldn't get those ones was because our physios were located in metro, inner and outer regional areas. So from an equity point of view, I think, telehealth can help improve health inequity by increasing access for people in geographically remote areas. And I think that's where the focus always is on, we can get more people in rural areas can access care. But I think we shouldn't forget those people in metropolitan areas who don't have transport, who can't afford transport, or who are in such pain or so frail that they actually physically can't get out to an appointment as well. So it can help improve inequity there. However, inequity can also come from people who are financially disadvantaged, and we've talked about who don't have the technology, who don't have the smartphones, who don't have broadband, who often come from ethnic minority groups or quite socially disadvantaged groups. So it is a really important consideration that we think about there.
Yeah, so I guess further to that point, in regards to people that don't necessarily have access to technology, so look, within public health, it might be a little bit easier than within private clinics, where essentially you may have access to some technology that you might be able to loan out to patients. So, as you mentioned, Rana, earlier in our conversations, in regards to having a face-to-face appointment to begin with, where you might end up spending a lot of time educating somebody in regards to the technology that you're loaning them, for example, in order to try and, I guess, overcome that barrier. And the second point, I guess, with people that don't speak English is whether they've got family members that might be younger and maybe a little bit more technologically adept. And I have done this with other musculoskeletal patients, where essentially it's the grandchild who's essentially set up their grandparent, and logs in for them at that particular appointment time. And, we basically, and ends up semi-translating if there was no actual interpreter available. We used an exercise program where there are videos, so you could actually show the patient and then email basically a paper copy. Or again, if they had smartphones, you could basically email them a link so they've got the videos. So there are ways around it, but there are still challenges, and not everyone is going to be able to access the technology, and not every, practice or public hospital will have access to technology devices that they can loan out to patients, for example. So there's all of those elements. Interestingly, I think in some of the regional areas for other things, so like fracture clinics and stuff like that, and management, they've had community nurses where they've actually dropped the exercise programs off to patients and things like that. So again, that might be a way of, utilising primary health in regards to trying to help patients set up technology if they don't have it, and basically educate them on how to use it.
I think the other helpful thing that's improved a fair bit, especially over the last 5 years or so, a lot of my family's from country New South Wales, and reception for internet has been a major issue probably until like the last 12 months. We used to not get any form of internet or reception until we went into town. So that is slowly, I guess, improving for more of those rural areas. But like getting any form of even, I guess, your Netflix and things like that have always been difficult because I just don't have the access to the internet. And some of my family aren't even that rural. So I'm going to guess in other areas they probably have a similar issue. But I guess there's probably no overcoming that until your telco companies improve that aspect of it.
Yeah, definitely. I agree with Rhiannon there. I worked briefly for about 3 months or so out in Dubbo, and we would service areas like Warren and Lightning Ridge and things like that. So Lightning Ridge, for those watching at home, this is a really remote town known for its opal mining, sort of in the western part of New South Wales. So it's quite a fair way into the countryside. And their sort of closest hospital was Warren, which was quite a big drive to get there. So we're talking, sort of up to 8 or 10 hours of driving just to get to the hospital. So it was going to be beneficial for them to do telehealth options to save them driving time, but sometimes they didn't have the access to a telco provider that would, enable them to do the relevant telehealth. So they would actually have to drive to Warren just to do a quick appointment and then go back to Lightning Ridge. So it can be a really big problem in rural and remote areas of Australia.
All right, so we're coming to the end of the journal club. I guess I'll just give an opportunity for anyone is there anything, other points they wanted to raise or anything that we haven't talked about that they'd like to?
Not specifically in regards to telerehab. I guess more in regards to the non-inferior aspect to this trial, because I guess it's the first time I've actually read a non-inferior trial, and I guess trying to get my head around how you kind of set it up, because you kind of said that, for pain, I think it was 0.9 or minus, something like that. Then, if it was outside of that, then there was, I guess, inferiority aspects. So could you, Rana, kind of explain that aspect, if that's possible?
Yeah, the non-inferiority designs, they're different than the typical clinical trial, which is designed to test superiority. So in the normal clinical trial, you're hypothesizing that one treatment is better than another. And when you set up your sample size, you're doing that around how much better you think that treatment will be. And usually people are interested in detecting a difference that is of clinical relevance. So we would usually power a trial like that around perhaps the minimum clinically important difference or a clinically meaningful difference. In a non-inferiority trial, what you're hypothesizing is that that one treatment is not unacceptably worse than another. So what you have to do then is so it's a much smaller difference that you're looking for between the groups, and in fact you have to make the decision about, well, what is a difference? What difference would be allowable but not considered worse? So if we thought that in-person care is a little bit better, what's the difference that is a little bit better, but I wouldn't say that difference is worse if I was in telehealth, if that makes sense? And we call that the non-inferiority margin. And that's what you're talking about there. That's why those differences are quite a bit smaller. And that's why the sample size required for a non-inferiority trial is quite a lot bigger. And we interpret the findings quite differently, which I think Josh has put up in the presentation around it's figure 2 in the paper, where the critical thing that we're looking for here is, do those confidence intervals cross the non-inferiority margin or not? And if they don't, that's when we can conclude that this treatment is non-inferior. And in fact, with the non-inferiority trial, you could, if you're looking at figure 2B, particularly with function, you can see that the confidence intervals and the difference between the groups with function is quite a long way to the right and favours telerehab. And if those confidence intervals had have been with that at 3 months, just to the right-hand side of 0, we would have actually been able to conclude that telehealth was superior than in-person care for function. So a non-inferiority design does allow you to make those interpretations, and the data was certainly trending that way, but we did not land around us being able to say that it was superior. I'm not sure has that helped answer those questions?
Yeah, I think so. Thank you.
Now, I think the study itself obviously is great, especially for our service. Like, telehealth is definitely obviously a good option for self-management strategies. And as Rana's mentioned, it definitely empowers the patient and they kind of have their own independence. So, yeah, we offer it to everyone that kind of comes onto our service. I guess uptake is very well below obviously what the study has found. But yeah, our biggest two barriers are probably that non-English speaking and then just the digital literacy for it. So but yeah, overall, I think this was definitely a great article for physiotherapy, and especially obviously with those training aspects being still available that everyone can still access. So thank you.
And it's a good point to end on. So yeah, thanks everyone for contributing. Hopefully other people find this discussion helpful as they read the paper.